Hi everyone, Mike and Matt here. We've got another really special episode for you today, and really pleased to be able to welcome another guest to talk about a topic that has really been in the media a lot recently, and that's the subject of obesity medications, particularly obesity injections. You may well have heard about Ozempic or Wegovy or Mounjaro, and these are medications that are being used around the world and certainly in the UK. We can see pharmacies, supermarkets are offering these online. And what we wanted to do with this episode is really address the central question: do these live up to the hype? The talk evolved into something a little bit more, which is to talk about obesity in general. I hope you find it really interesting. I know we did. Addressing the issue of these injectables really only tells part of the story.
I was always brought up thinking that calories in, calories out was all a kind of physics equation, and it's been enlightening to learn more about it and considering obesity as a disease process rather than a lifestyle choice.
Welcome to Beyond the Limits with me, Mike Forsyth, and my co-host Matt Clark. Latest statistics suggest that in the UK, 26.2% of adults were living with obesity, and this number is as high as 40% in the USA. The financial burden on the National Health Service due to obesity-related illnesses was estimated at £6.5 billion annually as of 2022. Obesity is associated with at least 13 types of cancer. Estimates suggest that at least 22,800 cases of cancer annually in the UK are caused by excess body weight.
Wow, those are truly shocking statistics, aren't they, Mike? And with that context, it's super exciting to introduce our new guest to try and help us tackle this complicated subject and give us a bit of insight into these new medications. It is with great pleasure to introduce Dr. High. Dr. High is a Canadian board-certified internal medicine and obesity physician, as well as a certified life and advanced weight loss coach. Sasha is also the host of the superb High on Life podcast. So welcome, Sasha. Welcome to the Beyond the Limits.
Thanks so much, Matt and Mike, for having me.
Pleasure is all ours, I can guarantee you that. We're going to be speaking in detail about weight loss injections. Wondering if you would mind kind of kicking us off, explaining maybe some of your practice and your approach to obesity in general.
Absolutely. I think before we can talk about weight loss medications, and I prefer to call them obesity medications, before we can jump into that, it's really important for your audience to understand the pathophysiology that leads to obesity. And that's because our culture comes in with a lot of preconceived notions about what obesity is. It's, just eat less, exercise more. It should be simple. It's poor willpower. You have a lot of weight bias. And I know for myself, when I started understanding the physiology that drives excess adiposity and dysregulation in appetite, that was really what opened my eyes and dispelled a lot of my own biases, because I think we all have some degree of weight bias. So let's just go back for a second and understand, what is obesity? What are we talking about? Obesity is a state where excess adiposity, so fat tissue on the body, is leading to an impairment in health or function or quality of life. And what causes someone to develop excess adiposity? Well, if we understand that this is actually a disease of the brain, and the brain has several appetite centers, 3 different areas of the brain that control our appetite and our energy regulation. So the first area is our hypothalamus, and that is the part of our body that kind of keeps things in tight control. It's also our temperature thermostat. It's trying to keep our body temperature in tight range. It's also trying to keep our weight in tight range. And it does that by receiving signals, hormones and peptides from the periphery, so from our fat tissue itself, from our intestines, that communicate how much energy do we have stored, how much energy have we recently taken in, have we had a meal recently, have we not, and it's trying to keep things in a careful balance. And it does that reasonably well, and did so for thousands of years. But there's a second layer to this appetite system, and it's called the mesolimbic areas of the brain, and that's our pleasure-based eating. And in our current environment, where food is ultra-processed, what we call an obesogenic environment, this pleasure center of the brain overrides that tight homeostatic control. So what happens is that we are taking in a lot more food than our bodies actually need, because it's driven from this other part of the brain. And then we have this third layer of the brain, And this is the executive functioning. So the first two parts that I talked about, completely subconscious. We have no conscious control of our pleasure center of the brain. We have no conscious control of our homeostatic regulation. The only part where we have conscious control is the executive brain, and that's where we make food decisions, and we try to inhibit urges, and we try to make a great choice, and we try to reach for, the whole foods instead of the ultra processed. But that part of our brain is half asleep most of the time, and most of our lives are lived on autopilot. And so it's the complexity of these three areas of the brain in our current obesogenic environment, plus all these other factors like socioeconomic factors and medications that people get prescribed sometimes and mental health issues that cause appetite and weight dysregulation. And the reason it's so important to start there is because then we can understand how the medications work. So when we understand that this is starting in the brain, then we can have the conversation of, okay, the newer medications that are coming out that exist now and what we're going to see in the next decade, I think, are all medications that are actually targeting these different appetite centers in the brain.
Really, really useful to hear that overview. Just listening to you talk, it makes me realize, I guess, how it's such a holistic area in terms of managing this, right? I know we're going to be talking in a little bit more detail about these obesity medications, but I think really useful to hear that.
I think about this obesogenic environment and how this seems to be a new man-made problem, and that we're so in many ways manipulated by products and the marketing of things that aren't particularly good for us. And you talked about this subconscious control of it and just how easily we are related by the food products that we're surrounded by now. It outlines nicely where we're at and how we might have got here.
Yeah, I think it's really helpful too to dispel some of the intrinsic weight bias that a lot of patients with obesity or people living with obesity have, often towards themselves, right? They're judging themselves as I failed. I couldn't diet hard enough. I just don't have enough restraint. I don't have enough willpower. But I think it's so helpful to understand that our brain, that mesolimbic part of our brain, is the most important part for our survival. And it seeks out calorie-dense foods and causes us to have cravings and want food. And if we look at human history, where food scarcity was more common than our current situation, where there's plentiful food everywhere around every corner, in a setting of food scarcity, it was beneficial to have a brain that caused us to go out and seek calorie-dense foods because that's a survival advantage. It's just not helpful now, right? Mm-hmm. So now it's like these foods have hijacked this part of our brain. So it's not your fault, right? Like that's what I often communicate to my patients. This is not your fault. Your brain is doing what it's supposed to be doing. It's seeking out those high calorie dense foods and making you desire them. And that was beneficial throughout human history. But now we have foods that have totally kind of overridden our normal ability to control and created a situation where the vast majority of us consume more than we need, right? We're overeating. We're eating foods that taste really good because that's what the food industry wants us to do. And for some people, genetically, they can just get away with that more. For other people, their body, for a number of reasons, is going to hold on to that more. And so there's more adipose tissue deposition. And there's genetic differences there too. And I think even understanding the genetic differences among individuals really helps to dispel bias, because this is not you failing. This is your genetics are more prone to this. That doesn't mean we can't do something about it, but it does say, hey, this isn't your fault. You didn't fail. This is not you not trying hard enough. You've probably tried 20 different diets before coming into my office. It's that you've got this genetic predisposition in our current obesogenic environment, and it's led to, challenges with managing weight.
Sasha, I wanted to ask specifically about these obesity medications, because I know that's primarily the focus of what we're dealing with today. If you can, are you able to just give an overview of what these drugs are and essentially how they work, what their mechanism of action is? Yeah,
absolutely. So the main medications that we're talking about that are really popular in the media these days are the GLP-1 class of medications. There are others, but these are the ones that most people are maybe familiar with. So GLP-1 is a peptide that is naturally produced by all of our bodies in our small intestine. And it has a number of roles. It acts on the brain. It communicates with that homeostatic control within the brain to tell our brain that we've recently had a meal, and it can shut off appetite. GLP-1 also communicates with the pancreas and produces insulin secretion to try to lower blood sugar levels. There's also GLP-1 receptors in our stomach, and that slows down the passage of food. And so these medications mimic our natural GLP-1. So they're called GLP-1 receptor agonists. They're made to do the exact same thing as our own innate GLP-1. And so the mechanism of action is really understanding everything I just described with those 3 layers of appetite. GLP-1, when taken with the medication, is going to really shut down appetite within the brain. And there's some effect on the mesolimbic area of the brain, so that desire for food. So what a person will experience is, a lot of patients will talk about food chatter and constant food noise. And that's a genetic predisposition to have a brain that is kind of thinks that it's starving all the time. And so it's always thinking about food, thinking about when am I going to get the next meal? Have I had enough? I'm hungry for more. What can I eat now that's going to taste good? All of that gets quieted with these medications. And you might have half your meal and be totally stuffed and not able to have more. So it's going to decrease intake of food because of this central effect on the brain that then leads to weight reduction. There also are effects on the stomach. As I mentioned, it slows down the food moving from the stomach into the intestines. And then it also helps with blood sugar control, which is why we use these medications in the context of type 2 diabetes as well.
This might be oversharing, but I was quite a big kid. I was really chubby as a child. I was also quite a stocky teenager, and thankfully I'm a much more healthy weight now. But I definitely tried some diets as a teenager. I was interested when I read about these products because of how they reduce appetite. And I've read that, this is a magic drug, this is a game changer. I've seen it described as the holy grail. It's really interesting how they seem to kind of suppress that appetite, because definitely when dieting or kind of diets, which obviously we're not going to endorse today, but you're battling constantly with this hunger, and it's essentially relying on willpower, and willpower is relatively in short supply with most people. Fascinating how that mechanism might work and how it may actually help just reduce that, like you said, that food chatter. Now, I've also read that these drugs are pretty game changing. I've seen clinical trials have shown, between 50 and 20% weight loss, depending on, what specific weight loss injection you're referring to. But these are huge amounts of weight loss, shorts of time.
I think for many patients, it is very life-changing, particularly patients with chronic obesity who have come in really feeling like they've tried everything. And they really have tried so many different diets. They just haven't had the right treatment. And when they start these medications, it's almost like this mental real estate that was so taken up by food preoccupation and diet preoccupation and weight loss preoccupation. All of a sudden, you can think about more important things in your life. And so just that one effect is so helpful for many patients. But then to be able to actually successfully lose the weight that they've tried so hard to lose and maintain that weight loss, it just, improves so many cardiovascular risk factors, cardiac risk, but also quality of life changes to such a degree. Confidence can change. And then interestingly, it actually really empowers people to engage in health behaviors much more easily as well. And I think this is important to note because there's a lot of criticism around these medications, like you're cheating by using these medications. Why don't you just work harder? But as you just said, willpower versus 24/7, 7 days a week physiology is really hard. Your willpower is not going to win in that situation. That's what so many people have experienced. But as soon as you address the biology, all of a sudden it's like, I can make healthy choices when I'm not having cravings all the time. And I can kind of have a smaller portion size when my brain is not starving. It actually facilitates the behaviors that people have tried so hard to stick with, but thought that it was their own fault that they couldn't. Now, there's still behavioral skills and tools and cognitions that have to be addressed. And the whole lifestyle piece is absolutely important. But it's often that the medications facilitate the healthiest lifestyle.
And just in terms of who gets these medications, is it a certain BMI? Is that how it's clocked in your practice? And associated health conditions, do they play a part in this as well in terms of the choice of whether to start this?
So the Canadian Obesity Guidelines is what I'll reference in terms of what's recommended. And interestingly, the Canadian Obesity Guidelines have kind of set the precedent across the world. So it's kind of a plug for Canada. The guidelines still go based on BMI. And this is a shortcoming that we don't have there's so many attempts to really define obesity and have better ways to select people who are appropriate for treatment. Officially, it's BMI greater than 30, which is the definition based on BMI of obesity, or greater than 27 with a weight-related comorbidity. I consider it a loose guideline, and I don't necessarily follow that. And here's why. There are so many people of different ethnic backgrounds who they just have a smaller capacity for fat storage and will develop metabolic conditions so much sooner with a smaller body size. So their BMI might be 25, 26, but they've got prediabetes and fatty liver and high cholesterol. That is a person who has adiposity leading to impaired health, right? And if you recall, that was the definition that I gave at the beginning of what obesity is. So there is a lot of clinical judgment here of looking at, is the adiposity causing health conditions? And that's where the comorbidities come into play. And we're really looking at how is it impairing their function?
Yeah, absolutely. And that's a similar guidance in the UK in terms of BMI. So I think it's 30 or 27 with associated comorbidities. I wanted to ask a little bit about side effects, because obviously that's a concern with any new medication. People have told me about horror stories of people taking these medications and having significant GI side effects. But in terms of your practice, what are the things that people regularly complain about, and are there any side effects that people should be concerned about?
Yeah. I think this is one of the big questions that patients come in with as well. And my first statement would be that I believe that the side effects are very much overstated in the media. And even I recall last year when Ozempic became really popular in the media, and then the media decided they were going to talk about how bad it is, right? And all the terrible side effects and gastroparesis and all these things that are not really true. It's all twisted. In my experience, and I've been doing this for a really long time with a lot of patients, if it's done appropriately with the right patient, with good supervision and good counseling, we can minimize the side effects. So what are the side effects? The most common are the gastrointestinal side effects. So things like reflux, nausea, constipation or diarrhea. Those are fairly common side effects. We know that from the clinical trials as well. But the vast majority of people experiencing GI side effects should be fairly mild to moderate. This is not the person vomiting every single day. I would never want that for myself. I would never want that for one of my patients. Where we see that, and where, there's people who talk about that online, how atrocious it was, is often people who don't get good counseling. They're just escalating the drug dose because they're trying so hard. They want to lose that weight quickly, and they're doing it faster than they should be. So there are guidelines of how to titrate the dose. So all of these medications start at a low dose and then slowly increase over time. And it's usually on about a monthly schedule. So you do it for a month and then you increase it for a month. However, the counseling I will often provide to my patients is, I want you to feel better on the existing dose before you do a dose increase, because it's dose dependent, the side effects. And so if you're already not feeling well and then you bump up the dose further and you just kind of tough it out and then you bump it up further, you're going to feel terrible. And there's just no benefit to that. You're going to have a bad experience. So I give my patients a lot of autonomy and a lot of education to really minimize those side effects. So the GI side effects are common, but should be fairly mild. And then there's the rare side effects. So, drug-induced pancreatitis is something that people talk about. Gallstones. Gallstones are really common with significant weight loss, right? We know that causes gallstone formation. And so these are things that we counsel our patients about. But what I think happens sometimes is we hyper-focus on the downsides of the medication. But the counseling I like to provide is we have to have a more balanced view. Yes, there's going to be side effects. Every drug comes with some degree of risk, right? But we also know that obesity carries very significant risk. And you mentioned it, cancer. It's like the number two risk factor for cancer, preventable cancers after smoking, and cardiometabolic risk. We know that. But when we're thinking about side effects of the medication and we take that out of context and we make that seem really bad, then potentially patients are not going to get access to something that's actually overall in the big picture, the benefits are going to greatly outweigh those risks because the risks of ongoing obesity are so much higher.
It's really interesting to get that balance, isn't it? And emphasize how this, in many ways has been described as the Holy Grail. All of those risks, if you can improve someone's situation and prevent some of those terrible conditions, it really is life-changing, isn't it? I'm curious to know, with you said that you've got thousands of patients now taking this, are you seeing any kind of unexpected things, like when patients try to stop the medication, or are they seeing any tolerance to the medication?
So I would say both of those things are a yes, but neither of those are unexpected. Let me explain that a little bit more. These are not medications that we really should be stopping. So that's a bit of a misconception too in our culture, is that, oh, I'll just take it, and once I've lost the weight, I'm going to come off the medication. So we really need to go back to understanding obesity is a chronic disease. These medications are not a cure. There's no medication that we currently have where you can take it and you lose the weight and then you can stop it and you're fixed. That doesn't exist. And so when we understand it's a chronic disease and we kind of go in with eyes wide open, like if you had hypothyroidism, you're probably on Synthroid for the rest of your life. If you have high blood pressure and your blood pressure comes to normal range, you don't stop your medication. You continue to maintain that. It's the same thing with obesity treatment, but for some reason we have a hard time wrapping our heads around that. But that's generally what we need to be thinking about. And I don't ever say forever, because that's like a scary thought. Who knows what's going to happen? Maybe another medication comes out in 10 years that is a cure, right? And then you go on that. But we need to go in thinking not that this is a kickstart, because it's not a kickstart, that we're treating a chronic condition and that we're likely going to be taking this medication indefinitely. Because if we stop treatment for a chronic condition, it comes right back. So weight regain is not unexpected. That would be the first one. The second one that you commented on is the tolerance. And again, when we understand the physiology of obesity, it makes sense that as you lose significant weight, the body has a lot of defense mechanisms that kick in. So let's say you take the GLP-1 medication and now you've lost 15% of your body weight. The reason it will seem like the medication's not working as well, I'm not having as much appetite suppression as I was when I first started and it was so easy. Now I'm having to work harder again. I'm having to apply some other tools and skills and, self-monitoring and all of the other behavioral tools that are important. The reason is because now you're 15% down. So your body is down 15% from the set point that it had developed. And leptin is down. That's an important hormone. That signals starvation to the brain. Not only that, your metabolic rate has reduced. So now you have to eat less just to maintain that lower body weight. So all of these defense mechanisms are at play. And so that is when you need the medication the most. And that's when it's the high risk time, because patients think that's when I'm going to stop the medication. And it's like, no, that's when you need the medication the most, because maintaining that weight loss is way harder than losing it in the first place.
I think in my mind, certainly, as I said, we've got fairly limited experience with these medications so far. In my mind, I'd sort of viewed it as a bit of a kickstart. So in that kind of, when you see those patients who are perhaps stuck in that slight doom loop of, they're getting a lot of knee pain, a lot of osteoarthritis from excess weight, but they can't lose the weight by getting active because of the knee pain, and then because they can't exercise, they get heavier. And I guess in my mind, I was thinking, well, look, this is a situation where these drugs might be amazing, because actually we could lose 15% of the body weight, and then that allows you to bring in everything else. But it's very interesting to hearing that opinion in terms of actually the need in most cases to continue with this.
Yeah, so that's what the clinical trials support as well. We have the Step 1 extension trial, which was for semaglutide. We have the SURMOUNT-4, I believe it was, for tirzepatide, and these were withdrawal trials. So let's see what happens when we take people off the medication. And not unexpected, the majority of patients regain 2/3 of the weight lost within the first year, and kind of we're ongoing on that upward trajectory. But that's what we see. That's why weight cycling is so common. And Matt, you talked about it earlier with your experience of dieting and then feeling like you're starving. It's exactly what's going to happen if we help patients with the medication. They lose a whole lot of weight, then we take it away. Now all of a sudden they're starving and we're like, okay, good luck. Like, hope you can keep this weight off. And it's so difficult. So the majority of patients need to stay on. Now, there's about 16% of people who are able to come off the medication and maintain. We don't exactly know why. I have some hypotheses about that. I actually just recorded, I think next week's episode is talking about that on my podcast. But, we can't fully characterize who those people are. And so I think often patients are going to want to try. But this is where we want to do it with close supervision of a medical provider, because what we don't want is they come off the medication, now they're struggling, they regain all the weight, and then they're like, okay, I'm going to come back and let me try it again. Once they've done that weight cycling, in my experience, and this is anecdotal, we don't have data on this yet, it seems a whole lot harder the next time. It's like the medication just doesn't work as well. And in my mind, that makes sense because of what we know happens with metabolic adaptation. You lose weight, your metabolic weight rate decreases. You regain weight, your metabolic rate doesn't recover. So every time you're doing that, you're setting yourself back a little bit. And that's That's what I've seen in practice, certainly. I had a lot of patients who, when liraglutide was the first GLP-1 to come out, they went on that, lost weight, then they stopped it for various reasons. Family doctor didn't know, thought it was a kickstart and stopped it, regained all the weight. Then they come to me and now they're trying semaglutide, and we're just not seeing the same benefit as if they had just been GLP-1 naive and hadn't had that weight cycling with it. So I think that's an interesting area. It'd be interesting to see more research on that. But I think being really careful to slowly titrate down, monitor how is the patient feeling. If they're struggling, if they're having a lot of appetite, often they themselves will be like, no, I don't want to go back to where I was. Like, let's go back on the medication. But if they start regaining any weight, to kind of be quick to reinitiate.
It's interesting. It plays into a little bit of a worry I have about this, and this is more about the access in the UK in particular, but I don't know if it's the same in Canada, but a lot of companies, supermarkets, pharmacies are now offering this online for cost, and they say in their small print this should be done alongside support, and they might have an AI chatbot or something to help along the way. But it worries me a little bit, if that is your first exposure to these medications, are we losing that opportunity? Whereas if you get someone who knows what they're talking about and who can guide you through this in a holistic way, that's the win, essentially.
I mean, I absolutely agree. And I hope that your listeners hear the message that if you're going to, these are great tools. These medications are very good tools, but they need to be taken in the right context with appropriate supervision with someone who knows what they're talking about. And understanding that all these companies that are coming out, selling it at cost, they're seeing the opportunity. There's a huge opportunity here. This is a multi-billion-dollar industry. So there's a huge opportunity to make a lot of money. There's a whole lot of people taking this inappropriately. They hear it, they see it in Hollywood, celebrity culture. They're just doing it to get skinny or whatever that is. But then there's patients who really would benefit, but take it inappropriately, don't get the full benefit, maybe have that weight regain. And my concern is that we're just creating another diet, another thing that they're going to try, lose weight, regain, and be like, oh, another thing that didn't work for me. It's like, no, you just didn't understand. You didn't have the right counseling, right? And it just perpetuates more diet culture and more learned helplessness. And so I hope your listeners will seek out the right medical support if they are considering these medications.
Talked about the potential abuse and maybe the people who are taking this who might not need it. Definitely researching prior to this podcast, I've listened to a few episodes where people are just openly discussing their weight loss medication and saying actually kind of fairly athletic people in this context of taking it just to lose that extra bit that they can't seem to get rid of. I'm just wondering, other than maybe losing the first opportunity who are obese to actually make a meaningful impact, those scenarios where people might be taking it inappropriately, what are the risks other than maybe the tolerance? Are there any other risks that people should be aware of who are doing that?
I think the risk is a huge unknown. It hasn't been studied in that population. These medications haven't been studied in healthy individuals who don't have obesity. And that's why even really reframing our language from calling them weight loss drugs, which seems like, oh, anyone can use them to lose weight, to obesity treatment, right? We're not just trying to get everyone skinny. And so I think that's an important differentiator. We have no idea. If you're taking this because you're just trying to get skinny, you don't have obesity, you don't have other health conditions, you have no idea because you have not been researched. And so, are you losing muscle? Probably. Are there other risks? We don't know. Yeah,
I was going to ask about the muscle loss or the sarcopenia side of things, because if people who are taking it who don't need to lose weight might end up losing muscle, but are there also people who are needing to lose adipose tissue, i.e. the obese? Are you finding that there is a bit of a dependence and they might get a bit lazy with their exercise or other important aspects of their weight loss?
Maybe I'll answer, we can talk about sarcopenia and then I think they're two separate things, like this comment about laziness. We all have a tendency to do less exercise, right? Our human nature is to eat more and exercise less. That's just human nature. So you have to use a lot of effort to override that biology, right? So that's very common and why I talk about lifestyle all the time. I'm a huge proponent for healthy living. It's often the topic of, my conversations. That's not because the medication necessarily, that's just human nature. With the medication, we do know that there is a risk of muscle loss, and we don't have a whole lot of studies on this because most of the randomized controlled trials just looked at weight loss, i.e. the change in the number on the scale. When you lose weight, we have no idea when you're just looking at the scale, is that fat that you're losing? Is that muscle? Is it bone? And what proportion of each. So there have been smaller studies. Part of the STEP trials with semaglutide did look at DEXA scans. So that's a low dose radiographic scan that can give us a more accurate picture of body fat percent versus lean tissue and muscle. So there are some studies, and what we know is on average with any weight loss intervention from bariatric surgery to lifestyle to medication, about 2/3 of the weight lost will be fat and about 1/3 will be muscle. And that's across the board. Now, there's huge variability in terms of patients themselves. Some will lose no muscle and some will lose 40% muscle. And a lot of that is lifestyle. So if you are not moving your body, not doing anything to maintain muscle, not eating, not nourishing your body well, not getting enough protein, you're going to be at higher risk of losing muscle along with the body fat, and then kind of at setback, right? Because muscle is that's like the energy powerhouse of our body. The less muscle you have, the less you're going to be metabolically active, the less you're going to be burning. And that means over time, you can eat less and less and less food. So even eating normal amounts, your normal amount is going to be overeating for your body if you lose muscle mass. So I talk a lot to my patients about the importance of maintaining, and building is even better, but at least holding on to the muscle that you have, because we know that once you hit 30 or 40, you're losing about 1% muscle mass per year just with aging. Throw in a GLP-1 medication and a significant weight loss, and you're now potentially losing more muscle, and we don't want that, right? So when I think of these medications, I think in the context of how do we help patients with optimal weight loss. And when I think of optimal, I'm thinking that we're maximizing fat loss, but maintaining muscle mass as much as possible while still nourishing their body and caring for their body.
Matt and I were talking beforehand about these drugs, in particular, any other potential uses. I don't know if you know much about this, but the potential to be used with addictive behavior. I guess this all comes back to the physiology that you very eloquently explained early on. Is that something that you know much about, or have you come across at all?
Yeah, I think this is such an interesting area of seeing the other applications for these medications. So with the physiology, addictive disorders, that is in the mesolimbic area of the brain. So that those limbic pathways that are mainly dopamine driven, the pathways that seek pleasure, that is kind of what leads to addiction, whether it's food addiction, whether it's, other substances, alcohol. And interestingly, there's case reports coming out of patients going on these medications and finding that alcohol dependency reduces. And so I think this is an area of study. It's really exciting to see that. And it does make sense when we look back at the physiology. We're also seeing maybe a trend towards reduction in dementia and Alzheimer's disease, specifically a recent study looking at I think it was from Veterans Affairs in the States, looked at about 2,000 patients and found a 12% reduction in Alzheimer's disease in those taking GLP-1 medications. We already know that there is improvements in things like fatty liver, sleep apnea, heart attack risk, a 20% reduction in patients with obesity who have pre-existing heart disease who take these medications, 20% reduction, which is very dramatic. It's a very significant reduction, and we know that from the SELECT trial. So, these are not just about less adipose tissue. There are so many other health conditions that are associated with that excess adipose tissue. And there's the effects on the brain that may enhance cognition as well. So I think it's really fascinating. It's kind of an exciting field to be in.
Wow. I mean, that is breathtaking, isn't it? You can see why the hype is there, what to kind of keep an eye on. Moving this forward then. So I think the medications aren't your entire area of expertise. Is it worth just mentioning kind of other aspects of weight loss you think are important, or?
Yeah, so we've talked about the pharmacological treatment, but there's also the behavioral and cognitive. And when I say that, people think, what are you really describing? And I think of it as the separation between what we know we should be doing and actually doing it. So a lot of people, they know what healthy eating is. They know that they should be exercising, X number of minutes a week. They know that they should be sleeping earlier and getting more hours. They know they should be doing stress management, but there's the lack of implementation. And that gap between knowledge and implementation is where cognitive behavioral skills, whether it's cognitive behavioral therapy or other forms of psychological intervention, are really important. It's not that people are lazy, so they just don't want to do the things they know that they should be doing. It's that barriers come up and stress enters in and becomes our comfort. When we're stressed out, we grab that extra glass of wine, or we're snacking in front of Netflix in the evening. And so there's these behaviors that we engage in that have nothing to do with the nutritional value of food or, knowledge of calories and macros, but it's our relationship with food and how we're using food. So, you might think of that as stress eating, emotional eating, binge behaviors. That is very prevalent, particularly in patients with obesity, and often not addressed, and not addressed certainly with dieting. Because dieting assumes that if we just tell you about calories, that you're not going to engage in these behaviors. But no one cares about calories when they're just wanting to veg out after a stressful day with a bowl of chips at 9:00 at night. There's no discussion around calories at that point, right? It's about how do you learn to cope with life when it's not just turning to food. So that's a big part of it. It's even things like understanding hunger and how to approach hunger, and hunger not being this emergency of panic, I better just grab the quickest thing. Even that, or understanding how your environment might set you up for food cravings. So that's the skill set that I like to talk about, and it's learning skills and tools, and that's all it is. There's no magic to it. It's not willpower. There are very specific behavioral tools that can be really helpful. Even, the simplest one is self-monitoring is a really great behavioral tool just to bring awareness to what you're doing. Because as I mentioned, most of the time we're in autopilot. So if we just do some self-monitoring, it's like, oh, I didn't even know I was eating this many, extra calories at nighttime in front of the TV. That would be one thing. And then the other big area where these cognitive behavioral tools are so key is in the area of setbacks and resilience. So people get discouraged easily, especially if you've had a history of dieting where you've kind of developed learned helplessness because you've tried dieting, it hasn't worked, you regain the weight. There's this, over time, people, get into this pattern of oh, I've messed up again, I'll start again on Monday, right? Or I'll start again on January 1st, fresh start after the holidays, January 1st, I'm going all in. So there's these extremes, and I describe it as all or nothing thinking, perfectionism. And that actually is a huge setback for people because you're either all in 100%, so strict with your diet, or you're out, right? And we have to find that middle ground where you can live, 75%, and that's good enough, but you can be consistent with that. And part of that is learning how to have setbacks well and not be totally derailed and now in a downward spiral for, days to weeks to months because you had an overeating episode. How do you make your next best choice? And that's a phrase I use a lot with my patients is, what's your next best choice? You could have completely eaten a box of Oreos 5 minutes ago and you feel horrible. That doesn't mean you can't make another good choice right now. It doesn't mean you have to derail the rest of your day because you've already quote unquote messed up. So those are skills that patients often need to learn. I think most of us need to learn these kinds of skills, and it's just not taught. Emotional regulation skills are not taught in school. And that often creates a gap. And that's kind of what I like to fill in with some of the work that we do with patients.
We always try and come up with a central question that we're trying to address in the podcast. And actually, looking back at the start of this one, the question that we were trying to address was essentially, are these medications the answer to the obesity crisis? Now, I think in hindsight, that's a massive oversimplification of the issue. But certainly listening to you talk, I take away from this that there's a huge promise with these medications, certainly as a very valuable tool in what is a holistic approach to obesity.
I think that's a great way to describe it. It's a tool in the toolbox, and they're very effective and very helpful tools when used appropriately in combination with the rest of the picture, which is that holistic treatment, addressing the psychological factors, the emotional factors, the behaviors. But these are very helpful medications that for years we didn't have. We didn't have something that, was this effective in helping our patients. And so it just was about willpower and calorie counting. And now we have something that can be very life-changing, not only emotionally and socially, but from down to cardiometabolic changes within the body. It's very, very effective. Have the potential to increase longevity and reduce cancer risk outside of just, talking about the 10 to 15 to 20% weight loss. It's like the weight loss is just the means to a bigger picture, which is we want our patients to be able to live well, to live healthfully, to have an increased health span, not just increased lifespan.
I saw a photo and looking at someone who was discussing kind of the obesity crisis in the UK. It was a photo of a beach on a sunny day, which I've got to admit are pretty rare in the UK, but it was a sunny day, and looking at the kind of average person on the beach sunbathing, they were all pretty much a normal weight. And this was in the 1970s. And the comment was, look how our society has changed. And I think, without giving any kind of specific stats on that, this photo was quite shocking. Our new normal is that there is a huge problem with people being obese. And I just wondered, kind of zooming out from a societal perspective, just looking at if these medications clearly are quite game-changing and are having such a huge impact. It's been great to have you on, who's used such experience with these medications. Me and Mike as GPs in the UK, we're not there yet. This is kind of under specialist thing, but it sounds like this is something that's soon to come. I'm excited to see how impactful and how quickly this might change for us here in the UK and just generally people worldwide as well. So I just want to say a big thanks for coming on and some light on it. It's been a real pleasure.
Absolutely. Thanks so much for having me.
And Sasha, where can our listeners hear more from you? Are you able to add a little plug for yourself?
So my podcast is the High on Life podcast, and I have new episodes every Monday. I'm on Instagram at sashahighmd.com, although try to avoid social media as much as I can. And then my website is sashahighmd.com.
Can people find you from overseas? Is it strictly in patients at the moment who...
So I have my medical clinic is for Canadians only, but I have a whole coaching program for women, and that is international.
Sasha, thank you so much. A real pleasure to have you on.
Thanks, Mike. Thanks, Matt.